Executive Director of TADIS. And TADIS is an association of addiction treatment providers, certainly, but we also have a very diverse membership. We have people who are members who are drug court affiliations. We have people who are individual providers. We have prevention coalitions. We have recovery homes that do not provide clinical services, and many other people that are interested in supporting the addiction field. So we've become a very diverse group and one that's intensely interested in this issue in particular. TADIS doesn't provide any clinical services, but one of the things that we do have is called the Tennessee Red Line. And the Tennessee Red Line is actually a 24-hour-a-day, 7-day-a-week hotline for women, men, anybody who needs treatment referrals for addiction treatment and actually any kind of treatment in the state of Tennessee. And I want to talk a little bit about the hotline because we get calls from women who are pregnant who are seeking services. And I want to talk to you a little bit about how those calls go for us. Immediately after this law was passed, we got a flurry of calls of women who were very concerned about what that meant to their pregnancy. What happened at a statewide level is that there were a lot of women who were actually in treatment who left because they were concerned that it would affect their legal status, particularly with methadone clinics. There were a large number of women, I should say large considering the small population of pregnant women, which were a subset of that methadone clinic population. But we did have a large number of women who left. We started to get phone calls at TADIS about how to access treatment and what people's rights were and everything. And initially there was a flurry of women who sought treatment, but that died off within the first few weeks. And when you see the department's data, you'll also see that their data basically substantiates that. But what we did get is a lot of calls of women who were very concerned about how to access treatment, how to work with their OBGYN and others. And we got calls even from medical providers trying to figure out what to do and how to refer their clients to services. What we also started to get is women who started to get a little bit more savvy about the system, who realized that there are faith-based organizations out there who provide medical treatment free of charge, often for women who have no access to insurance. And if you go to a faith-based provider, there's no medical record of your treatment. It's not on your insurance, all those kinds of things. So we would get calls from pregnant women asking for faith-based treatment providers, wanting to elude the system. And that's certainly their choice. But please keep in mind that if you're a faith-based provider, you don't necessarily have access to the medical care that corresponds with having a licensed addictions treatment clinic. So it didn't necessarily get these women access to a standardized evidence-based protocol that would have been appropriate for somebody who's pregnant and using any kind of substances. I will say, every so often, we get a call that's very inspiring. We got a call a couple weeks ago from a lady who was 36 weeks pregnant, had been followed by her OBGYN the entire pregnancy, was in Suboxone treatment, and her OBGYN wanted her to call to make sure that she knew what resources were available so that postpartum she could get access to services. It was working. We don't get many calls like that, but every so often we do. And we're happy to say that we've taken a large effort to try to work with medical professionals and the Tennessee Hospital Association, the Tennessee Medical Association, to educate those providers about how to access the Red Line and how to find services. We don't always make those connections, but I think it's improving. We also get calls from people who are desperately trying to find services because the judge or their probation officer or somebody else tells them, I have to be in X kind of program. I've been court ordered into this program, I'm pregnant, and I can't get in. And unfortunately for those women, many of them can't get in because they're ordered into a program that's not appropriate. The program can't admit them because they're not appropriate. And so one of the things that we often do at TADIS is offer to call the judge, the probation officer, whoever, and say, this is what's actually available for this woman, and try to educate them a little bit about what services are and to make sure that the woman is not punished for not finding a service that's really not available to her. So know that that exists. The next thing I want to do is point out a TADIS article that we did about the impact of the fetal assault law. And I would say that it's not a complete article. It was a first attempt to document some of the issues around the law and how it affects women's access to treatment. But we're hoping to write a more enlarged version, a white paper that will document several other issues as the impact of this law has become more and more clear to us. But there are a couple things, and it's a long article, but there are a few things that I really want to point out to you about this impact. Treatment services in Tennessee are certainly licensed, I should say addiction treatment services are licensed through the Department of Mental Health and Substance Abuse Services. However, there are also hospital-based programs, hospitals that provide medical detox. When I talk about licensed providers, I'm not talking about those hospital programs. However, detox to abstinence for a woman who's pregnant is usually contraindicated. So most hospitals are not doing detox with pregnant women. Those women typically would come to an addictions treatment provider or some kind of supported residential treatment. So this article really focuses on the residential detox programs for which most women would seek that kind of care and support when they're going through treatment. There are all kinds of levels of care in that licensure system, including intensive outpatient treatment and some other things that you're going to hear from our provider panel, so I won't go into great detail. But just know that residential detox is not the only level of care that can be provided to these women. It is the typical entry point, though, for most women who need ongoing care while they're pregnant. One of the things I also wanted to point out is that, and some of the other presenters have talked about this, is that the treatment protocol that is actually indicated for women who are pregnant, and is the cited evidence-based practice by SAMHSA, is methadone treatment. That is a medication-assisted treatment that is long-term medication-assisted program that continues while the woman is pregnant and is potentially titrated down to an abstinence kind of situation once after they deliver. There is also the possibility of Subutex, what people often refer to as Suboxone treatment, but for pregnant women, the formulation is actually called Subutex. And that treatment is available as well. It's not been studied as much as methadone treatment has, so it's not an actual protocol that's been recommended, but it is under study in the state. Actually, Vanderbilt did a study recently with women, and they're going to talk about that. But because it's under study, it is something that is available, but it's not necessarily an evidence-based treatment or one that is promoted and sanctioned by medical professionals or by SAMHSA. However, if you're in a medication-assisted treatment protocol, you're going to test positive for opioids while you're pregnant. It is an opioid, and you're going to have that opioid in your system. And know that the likelihood of taking opioids while you're pregnant does not necessarily guarantee you will have a baby born with NAS. It's something that medical experts are still studying to try to figure out why some women have babies born with NAS and some don't, and they're both taking the same amount of opioids. So it's really not an indicator that, every woman who takes opioids when they're pregnant is going to have an NAS diagnosed baby. But that woman will potentially test positive and will potentially need to be in some kind of medication-assisted treatment or other kind of treatment while she's pregnant to ensure the safety of the fetus, because withdrawing from substances during pregnancy can have life-threatening implications, and I'm sure Dr. Young will talk about that as well. Just know that getting treatment does not necessarily reduce the risk of NAS, because if you get treatment, you're going to be on a substance that will just as likely result in an NAS diagnosed child at birth. Okay? So by getting people treatment, you're not necessarily reducing the possibility of NAS diagnoses. Okay? there are lots of things that prevent women from seeking treatment, but one of the things that I talk about in this article as well is how many facilities are actually available to women. Yes, there are 117, beds available to women across the state of Tennessee. But just because there's a program doesn't mean, first of all, that they treat women. Doesn't necessarily mean that they treat pregnant women. And so I basically did the research, and I called every treatment facility that was under this licensure category in the state of Tennessee, and I asked them how many of them treated women and how many would accept pregnant women. And we basically came up with 11 facilities across the state of Tennessee that would actually admit a pregnant woman. And of those 11 facilities, there's only 117 available slots for pregnant women across the state of Tennessee on any given day. Now let's think about how many women need those beds and how many beds are actually available. Now, if you do the math and you assume that the SAM statistics are correct, then at least 4,000 women a year who are pregnant would need access to some kind of addictions treatment during the course of their pregnancy each year. And you have 117 treatment beds available. There's not enough access. And when we get those referral calls on the red line, you get women who are desperate, who have called every treatment facility in the state of Tennessee, and there are no beds. And let's be clear, pregnant women are a priority for treatment by law. If a treatment facility has an open bed, that pregnant woman goes to the first of the line. But there's still a line. And you don't necessarily get access to a bed if there's no bed available. One of the key indicators of success of treatment and getting people into treatment is getting people into treatment at the point they're asking, and at the point they need it. If they don't get a bed that day, very often you lose track of them. They might go on a waiting list, but you can't necessarily find them for lots of reasons. But it's key that if you're really going to provide important care to women at a point in their pregnancy that they're asking for treatment, you need to be able to find a slot and need to be able to have enough funded beds that are available every day to be able to meet the need. And that's clearly not the case. This data comes from Department of Mental Health and Substance Abuse funded programs. These are state-funded beds for people who have no insurance and no other access to treatment. Pregnant women are a priority for these treatment slots. So for women who have no other access to treatment, this would be the way that they get it. The data comes from the department's data reporting system that providers are mandated to input into. And for the purposes of this data, narcotics was defined as opioids, which meant prescriptions, methadone, and heroin, including cocaine. So it's the same legal definition as what was referred to earlier by several of the lawyers as in the statute on the fetal assault law. Same definition. Okay, so this was the data set from January 31st, 2001. And data also from the recovery courts, which actually are funded through the Department of Mental Health and Substance Abuse Services. And they tried, in order to highlight the differences in the population, both before the law and after the law, they put the data into those two subsets. So you can see the impact of the law after it was passed in the data. Oops, sorry. So, I could go through each of the slides, which have actually been reproduced for you, but what I want to do instead is actually highlight some of the data points that are actually on the front page of your handout. Substance abuse treatment admissions of pregnant women did increase in the first 3 months after the law went into effect, yes. However, they then decreased after that, and that's potentially because of a lot of factors, and that's not really described in the data. Successful treatment outcomes for pregnant women were lower than for previous periods prior to the new law, and declined even further after the new law. There's been a lot of speculation as to why, but I think you can kind of speculate yourselves when you're at risk of all kinds of legal things happening to you, and that risk has increased, why that might be the case, but that is speculation. More pregnant women were using opioids or cocaine inter-treatment than women using other substances immediately after the law was enacted. And small numbers of pregnant women admitted to recovery courts prevented a detailed analysis of that population. One of the interesting things about that statistic is that the law would assume that if you get charged with this, that you actually go to a recovery court in order for adjudication of those charges. But there was such a small number of women who actually came in through that mechanism that there's no real meaningful data. Of the women who entered treatment immediately after the law changed, more pregnant women had an unsuccessful income than a successful outcome. Keep in mind that a successful outcome here is completion of treatment, among other things. Of the women who entered treatment immediately after the law changed, more pregnant women used opioids or cocaine than used any other substance. So there was a little bit of an uptick in terms of who was seeking treatment. And the percentage of pregnant women admitted to recovery courts remained constant after the law changed. So there's been no huge increase in the number of women that have gone through recovery courts or apparently been prosecuted under the law who have access to treatment because of it. The average percentage of pregnant women that were successful in the 12 months prior to the law was 45%, compared to 33% of pregnant women successful after 9 months after the law changed. So that's a pretty significant drop. And think about all the factors systemically that probably went into that. So I hope I've done their data justice. I don't really want to take responsibility for it other than that. But if you have any questions, I've been part of earlier presentations, so I'll try to answer them as well.